Next presentation is from Associate Professor David Anderson from the Burnet Institute, who is working to develop a simple blood test to detect HIV.
Thank you, Michael and Warwick and the NHMRC for this honour and for the opportunity to talk to you about our work today. I'm Deputy Director at the Burnet Institute in Melbourne, where I've been privileged to work with a large and diverse team of investigators, including collaborators in the United States, on a project that very much addresses the mission of the Burnet, which is to improve the health of disadvantaged populations worldwide, especially in resource-poor countries. And our project has been to try and develop a simple and inexpensive test for measuring CD4 T cells. And the reason that we need to do this is that in patients who are infected with HIV, the virus that causes AIDS, we have very good drugs. Those drugs are becoming cheaper by the day. But before we can treat patients with those drugs, we have to test the number of CD4 T cells in their blood, because we don't start treating people until their immune system starts to fail. And WHO recommends that patients should start therapy only once their T cell level drops below 350 cells per microliter. And that's when they start therapy. Now, for the roughly 2 million HIV-infected patients in the developed world, we have sophisticated laboratory equipment and well-trained staff who can do flow cytometry to measure the CD4 T cells. But it's quite expensive and requires a lot of infrastructure. And you will not be surprised to know that for the more than 30 million HIV-infected patients in the developing world, access to that sophisticated laboratory infrastructure is simply not available for many of them. And it's estimated by UNAIDS that around 14 million patients who should be on therapy lack access to therapy because they cannot get access to CD4 tests. The drugs are there, but they can't have the test that allows them to start taking them. And so there's a need for simple, robust and cheaper tests that can be used without the need for so much sophisticated therapy. And cutting a very long story short, we were able to develop a blood test that is very much like a pregnancy test. This is what the final prototype looks like, where we simply add a small amount of blood, which can be from a finger prick sample, to the test device. We then add some buffer. The cells that we want to test, the T cells, flow through into the device, while cells that we don't want to test, for example monocytes and red blood cells, are trapped in a filter paper. We then add some further buffer to rehydrate a colloidal gold conjugate, which gives the coloured reaction. And after a total of 40 minutes, we simply, by eye, can compare the intensity of a test line, which represents the number of CD4 T cells in the patient sample, to a reference line, which represents the cutoff. And if the test line is stronger than the cutoff, then we know that they don't need therapy. And in independent trials, as well as in studies in our own laboratory, we're seeing greater than 95% accuracy for detecting those patients who need to start therapy. And remember, these are patients who formerly could not get therapy at all because they couldn't get a test. And, an example of studies from the Burnet and the Alfred is shown here, where the patients in green are those who should get therapy. And in this example, we were able to detect 100% of them. We've also been very fortunate to collaborate with a small company in Melbourne, Axon Limited, in the development of a handheld reader, which is not absolutely required. We can read our tests by eye, but the reader helps, especially in training, in manufacturing and quality control, and it removes the subjectivity of doing the visual interpretation. And we believe that this is going to really help us in maintaining quality throughout the world as this test is being used. The current status of the work is that beta testing of our final prototype is about to commence with our collaborators in the US. We have planned field trials in Malawi later in 2012, as well as earlier development of plans for India, Kenya and Papua New Guinea. And we're at the pointy end of negotiating with licensing partners for the CD4 test, because The only way this can make a difference to patients is if someone is out there selling it. At low cost, we expect it will cost less than $2 per test, but someone needs to sell it for it to get out to patients. And we believe that this should benefit millions of patients in the poorest countries of the world over the next couple of years. And with that, I'd like to thank my many collaborators and the NHMRC for its essential support along with our other funding bodies. Thank you very much.